These are the glomerular disorders characterized by loss of protein in urine. Protein loss is more than 3.5 gram per day. 4 things you should remember about nephrotic syndrome: proteinuria, low albumin, high lipid, and pitting edema. Albumin is major protein in blood and it is negatively charged. Glomerular basement membrane is negatively charged, thus it doesn't allow albumin to leak into the urine. In nephrotic syndrome, there is damage to podocyte causing loss of glomerular basement membrane charge and thus leading to loss of albumin in urine. Therefore, in nephrotic syndrome, we will see patients with low level of albumin. As we all know, albumin maintains the oncotic pressure. Low albumin means low oncotic pressure, leading to pitting edema in nephrotic syndrome patients. Liver compensates to protein loss by increasing synthesis of lipoprotein. As we know, lipoproteins carry lipid, therefore increased level of lipoproteins causes hyperlipidemia in nephrotic syndrome patient. Loss of immunoglobulins will increase the risk of infections. There is also loss of antithrombin 3 in the urine, and therefore patients will with nephrotic syndrome have increased risk of DVT, renal vein thrombosis, and varicocele. Read this question stem. 5-year-old boy periorbital and scrotal edema. Urine analysis shows 4 plus protein. Serum albumin is low. Cholesterol is high. Which of the following is most likely diagnosis? This is nephrotic syndrome. FSGS and IgA nephropathy will cause nephritic syndrome. Patient will have hematuria on urine analysis. Patient will have RBC caused edema in this patient is due to low albumin. Low albumin means low oncotic pressure. Low oncotic pressure allows fluid to leak into interstitial space, causing pitting edema. Read this question stem. 7-year-old boy swelling around his eyes and ankles. Urine appears frothy. Urine analysis reveals proteinuria. Serum albumin is low. Total cholesterol is high. This is nephrotic syndrome. Which of the following renal structure is most likely affected in this patient? Proteinuria, low albumin, edema, and high cholesterol. These are characteristic findings in nephrotic syndrome. Glomerular basement membrane is primarily affected in this patient. Glomerular basement membrane is negatively charged. It doesn't allow proteins to leak into urine, but in nephrotic syndrome there is damage to podocyte causing impaired charge barrier leading to proteinuria. Read this question stem. Patient with nephrotic syndrome has selective proteinuria. What is underlying mechanism? Podocyte injury causing loss of negative charge on glomerular filtration barrier, causing leakage of protein in urine, causing proteinuria. Read this question stem. Which complication of nephrotic syndrome is caused by loss of antithrombin 3 in urine? Loss of antithrombin 3 will lead to hypercoagulable state, increasing the risk of DVT or renal vein thrombosis and varicocele in a nephrotic syndrome patient. Option A. Increased risk to infection will be seen due to loss of immunoglobulins in urine. 7 things you should remember about minimal change disease. It is the most common cause of nephrotic syndrome in children, may be associated with Hodgkin lymphoma. Pathophysiology involves T-cell mediated podocyte injury causing impaired charge barrier leading to loss of protein in urine. It has excellent response to steroids. Light microscopy shows normal glomeruli. It shows negative immunofluorescence. On electron microscopy, there will be effacement of podocyte foot process. You should remember this sequence about minimal change disease. Child upper respiratory tract infection followed by proteinuria, low albumin, edema, and high cholesterol. Podocyte damage, effacement of podocyte foot process on electron microscope, excellent response to steroids. Read this question stem. 4-year-old boy, recent upper respiratory tract infection, edema, proteinuria, low albumin, high lipid. What is most likely subtype of nephrotic syndrome? It's minimal change disease. Read this question stem. 4-year-old boy, periorbital edema, swelling of legs, proteinuria, low albumin, high cholesterol, most likely diagnosis, minimal change disease. Most common cause of primary nephrotic syndrome in young children, minimal change disease. Read this question stem. Child with nephrotic syndrome, light microscopy and immunofluorescence are normal. Electron microscopy shows diffuse effacement of foot process. Pathophysiology of minimal change disease. T-cell mediated cytokine injury to podocyte leading to loss of negative charge. Option A. Immune complex deposition in subepithelial space will be seen in membranous nephropathy. Antibodies against glomerular basement membrane will be seen in Goodpasture syndrome, which causes nephritic syndrome, not nephrotic syndrome. Read this question stem. Nephrotic syndrome after starting a new medication. NSAIDs can cause nephrotic syndrome. Which of the following laboratory finding is most common characteristic of minimal change disease? It is selective proteinuria with normal complement levels. Rest of options are related to nephritic syndrome. We will discuss in nephrotic syndrome video. 6-year-old child with minimal change disease is started on high-dose prednisone, which is expected clinical response. Minimal change disease has excellent response to steroids. It's B. Dramatic response with a resolution of proteinuria within 1 to 2 weeks. A child with relapsing nephrotic syndrome responds dramatically to steroids with resolution of proteinuria within weeks. Which subtype is most consistent with this response? Minimal change disease shows excellent response to steroids. Renal biopsy is performed in child with nephrotic syndrome. Light microscopy and immunofluorescence are normal. Electron microscopy shows diffuse effacement of foot process. Most likely diagnosis, minimal change disease. Most common cause of nephrotic syndrome in children. 45-year-old man with Hodgkin lymphoma develops sudden nephrotic syndrome. As we know, minimal change disease may be associated with Hodgkin lymphoma. Read this question stem. It's a 6-year-old boy, not 36-year-old man. History of swelling and foam in his urine, low albumin, high cholesterol, proteinuria. Renal biopsy shows normal appearing glomeruli on light microscopy and no deposits on immunofluorescence. Which of the following is most likely on electron microscopy of this patient? Renal biopsy. Fusion and effacement of podocyte foot process will be seen in minimal change disease. Focal segmental glomerulosclerosis, most common cause of nephrotic syndrome in African American, usually associated with HIV, heroin use, sickle cell disease, and interferon treatment. Focal means less than 50% of glomeruli are affected. Segmental means part of each glomeruli is involved. Light microscopy will show sclerosis and hyalinosis. Immunofluorescence often negative. Electron microscopy will show effacement of foot process similar to minimal change disease. It shows poor response to steroids. It can progress to chronic renal failure. Read the question stem. Which nephrotic syndrome subtype is most common in African American adults and can be associated with heroin use or sickle cell disease? It's FSGS. Read the question stem. 32-year-old African American man with HIV present with nephrotic range proteinuria and edema. Biopsy shows segmental sclerosis and hyalinosis on light microscopy with foot process effacement on electron microscopy. It's FSGS. It's simple. African American HIV with symptoms of nephrotic syndrome. It's FSGS. Read the question stem. Which electron microscopy finding is shared by both minimal change disease and FSGS? It's effacement of foot process. Membranous nephropathy, primary due to antibodies directed against phospholipase A2 receptor, also known as anti-polar antibodies. Secondary due to hepatitis B, C, and syphilis infection, breast or pancreatic tumor, SLE, NSAIDs, penicillamine, gold salts, and dapsone use. It has poor response to steroids, can progress to chronic renal failure. Light microscopy will show thickened glomerular basement membrane. Immunofluorescence will show granular immune complex deposition. Electron microscopy will show subepithelial deposits of immune complex presenting as spike and dome appearance. If you see a patient with SLE with features of nephrotic syndrome, it's membranous nephropathy. But if you see SLE patient with features of nephritic syndrome, it will be diffuse proliferative glomerulonephritis. Similarly, if you see a patient with hepatitis B or C infection with features of nephrotic syndrome, it will be membranous nephropathy. If you see a patient with hepatitis B, C infection with features of nephritic syndrome, then it will be membranoproliferative glomerulonephritis. Read this question stem. 58-year-old man, solid tumor history, presents with features of nephrotic syndrome. Biopsy shows thickened glomerular basement membrane with subepithelial spike and dome deposits on electron microscopy. Diagnosis: membranous nephropathy. 55-year-old woman with features of nephrotic syndrome. Renal biopsy shows thickened glomerular basement membrane on light microscopy and subepithelial spike and dome deposits on electron microscopy. Most likely diagnosis: membranous nephropathy. Read this question stem. 55-year-old woman with diagnosed breast cancer presents with features of nephrotic syndrome like edema, low albumin, proteinuria. Which of the following is most likely to be seen on renal biopsy? It will show subepithelial immune complex deposits. I have already told you that if a patient with hepatitis B, C, or breast or pancreatic cancer presents with the features of nephrotic syndrome such as proteinuria, edema, low albumin, high cholesterol, that's membranous nephropathy, and biopsy it will show thickened glomerular basement membrane with subepithelial spike and dome appearance. Read this question stem. 61-year-old man. History of hepatitis B. Features of nephrotic syndrome such as edema, proteinuria, low albumin, hypercholesterolemia. That's membranous nephropathy. Hepatitis B infection plus features of nephrotic syndrome, membranous nephropathy. Read this question stem. Woman, history of hepatitis B infection, develops nephrotic syndrome. Most likely diagnosis, membranous nephropathy. Similarly, if patient develops hepatitis C infection and presents with features of nephrotic syndrome, it will be membranous nephropathy, most likely cause. 34-year-old woman, history of hepatitis C, features of nephrotic syndrome such as generalized swelling, low albumin, high cholesterol, urine dipstick shows proteinuria, renal biopsy shows granular dense deposits along the glomerular basement membrane, most likely diagnosis, membranous nephropathy. Read this question stem. A patient with hepatitis C and nephrotic syndrome, which of the following biopsy finding is most characteristic of membranous nephropathy? We all know in membranous nephropathy, we will see subepithelial granular dense deposits with glomerular basement membrane thickening. Diffuse effacement of foot process will be seen in minimal change disease. Mesangial IgA deposits with normal complements will be seen in IgA nephropathy, which is the cause of nephritic syndrome, not nephrotic syndrome. If they tell you in question stem, patient with hepatitis C and nephritic syndrome features, biopsy will show subendothelial deposits with tram-like appearance with splitting of glomerular basement membrane. That's feature of membranoproliferative glomerulonephritis, which causes nephritic syndrome, not nephrotic syndrome. 45-year-old woman with hepatitis C presents with features of nephrotic syndrome such as low albumin, protein, urea, which secondary cause is most likely reasonable for her nephrotic syndrome. It's membranous nephropathy secondary to hepatitis C. Read this question stem. Patient with chronic hepatitis C develops sudden edema. Renal biopsy immunofluorescence shows granular IgG and C3 along the capillary wall. This chronic hepatitis C infection with features of nephrotic syndrome, membranous nephropathy. Pathophysiology will explain that subepithelial immune complex deposition. Read this question stem. 29-year-old woman, hepatitis C, now develops edema, low albumin, protein, urea, electron microscopy of renal biopsy demonstrates subepithelial dense deposits. That's membranous nephropathy. Read this question stem. 42-year-old man, chronic hepatitis C with features of nephrotic syndrome, leg swelling, low albumin, high cholesterol, proteinuria. Biopsy reveals thickened glomerular basement membrane with granular deposits. That's membranous nephropathy. Read this question stem. 38-year-old man, hepatitis C, features of nephrotic syndrome, generalized swelling, hypoalbuminemia, hypercholesterolemia, heavy proteinuria. Renal biopsy shows granular immune deposits along the glomerular basement membrane. Most likely diagnosis, membranous nephropathy. Gold salts can cause membranous nephropathy. Look at this question stem. 52-year-old woman using gold salts for rheumatoid arthritis develops features of nephrotic syndrome such as bilateral leg edema, low albumin, proteinuria. This is membranous nephropathy. Biopsy will show thickened glomerular basement membrane with subepithelial immune complex deposition. In systemic amyloidosis, kidney is most commonly involved organ. Amyloid deposition in mesangium lead to nephrotic syndrome. Upon Congo red staining, it will show apple green birefringence under polarized light. In multiple myeloma, there is increased production of light chains of immunoglobulins. These immunoglobulins light chains get deposited in mesangium, leading to amyloidosis. Congo red stain will show apple green birefringence under polarized light. 62-year-old man, history of multiple myeloma, presents with features of nephrotic syndrome, such as bilateral leg swelling, periorbital edema, low albumin, proteinuria. What is the most likely cause of his renal findings? Renal amyloidosis. Read this question stem. 62-year-old man, multiple myeloma, presents with nephrotic syndrome. Biopsy with Congo red stain shows apple green birefringence. Most likely diagnosis amyloidosis. Read this question stem. 65-year-old man, multiple myeloma, develops nephrotic syndrome. Congo red stain shows apple green birefringence. Which subtype is reasonable? Amyloidosis. High serum glucose causes non-enzymatic glycosylation of vascular basement membrane in diabetic nephropathy. It will cause hyaline arteriosclerosis. Efferent arterioles are more involved than afferent. It causes high glomerular filtration pressure. Hyperfiltration leads to podocyte injury, causing leakage of protein and urea. It can progress to nephrotic syndrome. ACE inhibitors are usually used to prevent hyperfiltration injury. Biopsy will show mesangial sclerosis with formation of Campbell-Wilson nodules. Read this question stem. Patient with long-standing diabetes develops nephrotic syndrome. What is pathophysiology behind it? High serum glucose causing non-enzymatic glycosylation leading to glomerular basement membrane thickening and mesangial expansion. Non-enzymatic glycosylation of renal arterioles will lead to hyaline arteriosclerosis. Efferent arterioles are more affected than afferent ones. It will lead to high glomerular filtration pressure, causing podocyte damage. Hyperfiltration will explain the symptoms of polyuria and protein leak in urine. Read this question stem. 55-year-old woman, history of diabetes, has nephrotic syndrome. Biopsy reveals mesangial expansion and nodular sclerosis. What is the cause? Diabetic nephropathy. Read this question stem. 51-year-old woman, history of diabetes, presents with the history of fatigue and swelling in her face and ankles, with typical features of nephrotic syndrome such as periorbital edema plus pitting edema in lower extremities, proteinuria. Renal biopsy shows nodular mesangial sclerosis with Campbell-Wilson nodules. What is the mechanism reasonable for this patient's edema? Non-enzymatic glycosylation of renal arterioles leading to thickening of glomerular basement membrane with mesangial sclerosis. Podocyte foot process effacement will be seen in minimal change disease. Mesangial IgA deposition will seen in IgA nephropathy.